Thank you everyone for coming. Can y'all hear me okay? Unfortunately, um, I'm far more experienced with Zoom than I am with Teams. So hold on, I got another thing here. I'm far more experienced with Zoom than I am with Teams, so I'm not able to figure out how to get like the chat and stuff up at the same time. So any of your comments, Renee is going to be the moderator, and she'll kind of pop in to bring up any questions that are coming up at the same time. Also, one of the things we were trying to figure out was how the poll and the interactivity was going to work. We created poll questions in advance. We're not polling in the teams, so we're going to be doing something different. We'll see how it goes. This is the first time with this kind of new format, trying to do some more interactive stuff, especially with the remote folks. So we'll see how it goes. Thank you for bearing with us. I'm sure not everything will go right, but we'll go with it. Since there are no in-person participants, go ahead and if you can, scan the QR code with your phone or go to that URL, pollev.com/MacGobel368. That's going to allow you to participate in the interactive polls today. They're supposed to be, and I will try to get them to pop up in the Teams chat, but oopsie, that may be easier said than done because I need like a third monitor to be able to do that right now with presenter view and everything. So I'll give everyone a minute to try and log into that, and our first question should pop up shortly. I'll just give everyone a minute. Yeah, unfortunately, there's also a cap, I think, of like 40 people to be able to participate through this way. Because again, we were anticipating this being a hybrid, so we thought some people would be in person, so only the in-person people would be doing this, and we knew we sure as heck wouldn't have more than 40 people in person. So again, best laid plans, not necessarily going exactly as intended, but we'll give it a shot. So, how are you feeling? Excellent. Okay, let me see if I can get this. Now, in theory, this should pop up in the chat. Did that show up in the chat? Can someone tell me, Renee, maybe?
Yep, it's in there.
Okay, great.
Hey, Matt, it's
Yes.
Brian Fontaine.
Yeah.
I'm having an issue with getting on. It's pollev.com/.
So don't worry about the poll EV since we were able to figure it out with Teams. So just participate on the one that pops up in the chat.
Awesome. Thank you.
Yep. Yeah. So everyone, forget about poll EV. Sorry, I should have just tried to get the chat to the Teams thing to work since that's going to work. So don't forget about poll EV. Just participate in the poll that pops up in the chat. In the future, if you're participating remotely, this is actually the more important one. Again, the poll EV was intended for the people that are in person. The Teams chat and the Teams polls are they're linked to your attendance, so it shows that you were interactive during the session. It's part of like kind of what we submit with the state. It says not only was the person logged in for 100% of the call, but they also participated in 100% of the interactivity questions. So only 12 responses. I'm sure there's pretty more than 12 people on the call, but maybe only 12 of you are feeling good enough to respond.
Excuse me.
Mm-hmm.
The chat isn't working for me, and I'm also currently on shift, and if I have to go on a call, I would have to leave.
Okay.
But yeah, the chat isn't letting me in to do the poll thing.
Interesting.
If I may, I think the maximum allowed responses have been reached. That's why some people can access the chat poll that you send out in the QR code.
Yeah, so that's interesting that the chat isn't working, because the chat shouldn't have a limit. The QR code should. So, acts have responded. Oh, Lord. Again, first time with the new format. Sorry, everyone. Thank you for being patient with us. All right. So we'll move on to the actual content. This is going to be a respiratory M&M. I call it Janu Airway. So this we'll be talking about sort of anatomy and physiology, pathology, some sort of history and physical assessment kind of things. And then in terms of our therapies and interventions, we're talking about BVM and non-invasive ventilation. Next month, we're talking about supraglottics, intubation, and surgical crike or surgical front and neck access. And then we'll have a couple of cases that we'll go through. So starting with anatomy and physiology. So this is a section this way looking at the upper airways. The main thing that I want to point out here is sort of where our supraglottic airways enter. So we've got the nares, and then we come sort of through the turbinates here, which are supposed to warm and humidify the air before it comes down and towards the lungs. And then you've got the area here. This is your epiglottis. That's where your laryngoscope blade goes. This is the glottic opening where you put your tube down normally. So your supraglottic airways are supposed to sit right here. So that's where an LMA is supposed to kind of sit. And you can see the relative size of the tongue compared to the rest of the airways and how easy it would be for it to slide back and kind of obstruct things. And that's exactly what happens for patients that are unconscious, or if you have sleep apnea, might like me, just when you're asleep normally. The other thing to note here, the level of the vocal cords and the thyroid and cricoid cartilages. So the cricothyroid membrane is right here. So if you do a surgical cric, you are below the level of the cords. That's important because in an adult, the cords are the narrowest part of the airway. So you're going below the narrowest part, which is in theory where an obstruction would be occurring if one's happening. Moving on. So this is like a real-time MRI of someone's airway tissues being adjusted. So you can see here's the epiglottis and then the trachea right here. So this is what happens. You see we're doing that head tilt chin lift. Watch how this kind of lines up here. That lines up, stretches that out. All these soft tissues are straight. So you have a straight shot down into our airways when we're doing that head tilt chin lift. Which is how these basic maneuvers are working. And you can also see, here's the C-spine. So you can see how much the C-spine is or isn't being manipulated. It really isn't a whole lot of movement, well, except right there. If this is kind of an exaggerated head tilt chin lift, like you do with like the CPR mannequin, right? You like crank that head back. So when you crank it back all the way like that, you can see that it does actually move the tissues a fair bit. But just sort of putting into that neutral sniffing position, not so much. Which takes me to talk about positioning. So this is where most people are when they lay flat. You can see that nothing's really lined up here. Now, the demo that I like to do for this is when you ask someone to take a sniff of something. So I've got like this Sharpie right here. Okay, so if I'm off to the side and I want to take and I smell the Sharpie, I go like this, right? I don't go like this. Like we're doing with that head tilt chin lift. I pull I crane my face forward to smell the thing, right? And so you can see what's happening is when I come forward, I'm aligning the front of my face with the anterior chest wall just pushed slightly forward, which is sort of the true sniffing position, which looks something like this. We call this ear to sternal notch because you've got the opening of the ear canal, even with the sternal notch anteriorly. You just take that face plane and you push it forward. You can do this by ramping the patient, by sitting up the head of the stretcher and then kind of patting behind them a little bit. But this is the ideal position for airway management because you can see how all of those, you'd have a straight shot from the mouth and nose all the way down the trachea into the lungs. So similarly, here's how that anatomy lines up for our OP and MPA. MPA is coming down the nasal passages and then sneaking to down just above the tongue so you can kind of blow onto the glottic opening. And then the OPA over here is being used to keep the tongue from falling all the way back, including the back of the tongue or the back of the throat. So I guess this isn't a thing out here, but so when I was a paramedic out west in Utah, also this was overlapping with the fire service. When you dressed a hydrant like this was called a super plug. because you had something on each one of the outlets of the hydrant. So we would also do what's called a airway super plug, which means you got an MPA in each nostril and an OPA in the mouth. Now, there's no reason you can't do this, right? It's totally valid. It works. It actually works really well. So my question for you is, what is the most OPAs or NPAs you've used at a time? Okay, some people up to two. Two, most is two, 14 responses, up to two. Oh, someone's used three. I'm seeing in the chat, 2 NPAs. So I pulled the chat up on my phone so I can try to keep track of what's going on there. So it sounds like John T has done the super plug. All right. So moving on to the lower airway anatomy, this is everything from here down, right? So we've gotten past the last level of the cords into the trachea, and now we're in the trachea and sort of down to the lungs. So this includes the trachea, the main stem bronchi, the secondary, tertiary bronchi, the bronchioles, eventually branching down into the terminal bronchioles, alveoli, and diaphragm. So the alveoli. Now the thing here is the trachea, secondary, tertiary. That's just named for how they're branching on the way down. Until it gets to terminal bronchioles, which doesn't branch anymore. Then you get down to the alveoli. Now, the alveoli are the pulmonary. That's where the actual gas exchange occurs. So you've got the there's the area that's in contact with the air, and then there's the area in contact with the blood. And you can see here how they kind of are right up against each other. So they're in contact with pulmonary capillaries for gas exchange. Now, the inside surface of the alveoli is coated with something called surfactant. Surfactant structurally is actually kind of like a soap. It prevents the alveoli from sticking together and collapsing, which is a condition called atelectasis. So here you can, over here on the left, you can see how these structures kind of all work together. So you've got the blood from the right side of the heart, which is deoxygenated, coming in, and it follows the same branching pattern as the arteries, which are going to be carrying that oxygenated blood back to the heart, or excuse me, the pulmonary. Sorry, this is a pulmonary artery because it's coming towards it, but it's from the right side, it's deoxygenated, and then pulmonary veins, which are oxygenated, that's why they're red, going back to the left side of the heart. And then the trachea here, which is showing that same branching pattern coming down to here. Now, this is what these look like on a microscopic level, okay? So this is the alveoli down here. So this is this is a terminal bronchiole, and then a respiratory bronchiole, and then down here where it's like a single cell thick is the alveoli, which is where the gas change is actually occurring. And if we zoom in on that, these are the capillaries. See, this is literally like one cell thick of where the blood is going through, that's holding the blood in there, and the blood cells are going to flow right through here. And then this is air. And so you can see there's just like one or two cells that the oxygen and CO2 are going across, where the blood cells are kind of sneaking their way through here in order for that gas exchange to occur. And then we'll show some other pictures a little bit later of conditions where this gets all messed up. So let's talk about respiration. Respiration, inspiration and expiration. Inspiration is generally an active process, and expiration is generally a passive process. So when you inspire, the diaphragm drops, the external intercostal muscles contract, and we make our chest bigger. That creates a low pressure area, so we suck air in. And then when we expire, the muscles relax, and we create positive pressure and blow air out. Now, we can contract those muscles a little bit extra to get some extra air out. But in general, Inspiration is an active process and expiration is a passive process using those muscles. So if you have an issue with any of the structures or muscles or anything involved with this, it can cause a problem, right? So if you have a problem with the nervous signaling, that can happen with something like botulism, Guillain-Barré, any of the other neuromuscular disorders, affecting the signaling to the muscles. If there's a problem with the structure that the muscles are pulling on, so there's a problem with the bones, like flail chest, rib fractures, that sort of thing, can also cause issues with this. Trying to think of what else. If you had a issue with the actual degenerative problem with the actual muscles causing the specific weakness of the muscle tissues, that could also cause a problem here. So oxygenation. Oxygenation is really the process of getting the oxygen to the tissues. So you're inhaling O2 into the lungs. It's picked up on the red blood cells by the alveoli and then offloaded to the cells. Now, I just want to highlight this equation for just a minute, not because it's important to you understand or memorize the equation, but because I want you to understand sort of like what the levers are that we pull on to adjust the output here. So the delivery of oxygen is equal to cardiac output times this other thing. So delivery of oxygen is dependent on cardiac output. So when your body needs more oxygen, one of the things it does that it can do very quickly is increase cardiac output. So that's increased heart rate, stroke volume, right? It makes sense. You've probably all seen hypoxic patients that are tachycardic, and that's part of why that's the response, because they can increase the cardiac output very quickly to increase oxygenation to the tissues. Now, the other things to kind of note here, this is the other parts that we can adjust, that we can affect here. So you've got O2 saturation times hemoglobin times a large number plus partial pressure of oxygen times a small number. Now, this is just to say that oxygen saturation and hemoglobin are super important, whereas the partial pressure of oxygen is less important, meaning most oxygen is carried on the red blood cells. It's not dissolved in the blood, as opposed to the opposite of CO2, where it's mostly dissolved in the blood and very little is carried on the red blood cells. So your body can increase the heart rate, stroke volume. You can give fluids to try and increase stroke volume. You can increase the FiO2 to try and increase the oxygen saturation. And at the hospital, we may give blood to try and increase the hemoglobin, because all of those things are sort of the inputs that affect the delivery of oxygen to the cells. And of course, we're measuring the SpO2 by pulse oximetry. And I don't think that okay, share sound, good. So we're gonna watch this video clip. This is a demonstration of hypoxia. Please, let's see here. I'll be watching the chat here. Just let me know if you can hear the sound on this. Oops, down here.
And so we're going to start this hypoxia demonstration. Whoever has
It's all set.
used it for me. So what I'd like for you to do is to pick up a piece, hold it up, show everybody, and tell me what shape it is. It's a triangle. All right, so you're going to put it inside the box? Good. Okay. Next piece. Another triangle. Another triangle. Circle. Circle, no, it's a cylinder. It's a cylinder. Cross. Across. Square. Square. That's another cube. This is a cylinder. We also can see a little purple come around your nose and your lip area. This is a star. Now, before we do it again, let's put your pulse ox on your finger. We haven't done that yet. Let's try to check your O2 saturation and see what we're down to. You've been off oxygen now for 2 minutes, by the way. Roger that. Don, how you doing over there? I'm starting to feel like I'm going to black and white and the Looney Tunes kind of thing. My vision is going into just a central spot. All right, so Don, you can go back on oxygen anytime you want to. You don't have to stay off. I'd like to know what the O2 saturation is on your. And so we're going to start this hypoxia demonstration.
I know.
Again, let's put your pulse out of the way. Roger that. Don, how you doing over there?
So just by way of explanation, this is a YouTuber that I follow who's at a facility where they train pilots or they're having pilots practice to recognize the signs of hypoxia.
I'm starting to feel like I'm going to black and white and the Looney Tunes
Bastard, why did it do that?
And so we're going to start this kind of thing. My vision is going into just a central spot. All right, so
Okay,
Don,
so he's
you can
saturating
go
about
back on
70%
oxygen
right now.
anytime you want to. You don't have to stay off. I'd like to know what the O2 saturation is on your pulse ox there. What
70%.
does it read
See
now?
tachycardic 133, body trying to compensate for that
Okay, so
tachycardia,
that's a
or for
critical
that
area
hypoxia
here
by
where you need
increasing
to
the
start
cardiac
thinking
output.
about getting back on oxygen, because once you get below 60, death can occur just like that, right? So you got to realize that you don't want to die. Can we try the shape box one more time just to compare a difference between when you were just starting your demonstration versus right now?
Okay,
We can
setting
tell you're really starting to
63%.
feel the effects of hypoxia. Triangle? Yeah, what I'm interested in is to see what kind of coordination he has now. Starting to tingle. Yeah, you've been off oxygen for about 3 minutes 45 seconds. What is that? Square. And what was that one? That is a square.
So, question about the inaccuracy of low pulse ox readings. I assume, like most things, it's most accurate in the normal ranges, and it is less accurate the lower you get.
What would you do if you felt like you needed to get on oxygen? How would you correct for that? Can you correct for hypoxia for me? All right, so if you don't get on oxygen, you're going to die, right? You're not going to be able to survive this. Go to your regulator, get all 3 switches up on your regulator. All right, go to your regulator, get all 3 switches on your regulator. All right, let's go ahead and put him on for him. Let's get him back on. All right, let's continue on with the shape box.
See his immediate color change,
a square?
and he's
Yeah,
like
good
completely
deal,
back to
good deal.
baseline.
Circle? Look at that. See, that right there proves how much he's already gone from hypoxia back to feeling 100%.
Okay. So this is also why on an airplane briefing they teach you to put your oxygen mask on first, because there is not a whole lot of useful consciousness time at altitude without putting oxygen on. So in the time that it takes you to help someone else put their oxygen mask on first, you may lose consciousness, not be able to put it on yourself, and then you certainly can't help that other person. And then if you do put it on that other person, even if they've, gotten goofy or whatever, they're going to recover pretty quickly, because you saw how quickly he recovered once he put that oxygen back on. Right. So ventilation is the process of getting rid of CO2. Now, whereas oxygen is mostly carried on red blood cells, and very little is dissolved in the blood, CO2 is the opposite. It is mostly dissolved in the blood and very little is carried on the red blood cells. So we get this, this is eliminated during exhalation. We vary it with minute ventilation, and we measure it with capnography. The main difference, though, being that capnography is a combination of both ventilation and perfusion. So it's not the exact same as if we pulled a sample of blood and measured the CO2 there, because if that blood is not getting circulated through the lungs, then you can have a high CO2 in the blood, but a low end tidal. An example of that would be like cardiac arrest, right? There's probably a whole lot of CO2 built up in the blood, but the end tidal is low because the perfusion is low. But even though the blood CO2 could be high. So end tidal CO2, our capnography, is a combination of both ventilation and perfusion is the key learning thing there. Okay. How is this regulated? It mostly has to do with pH, which is the measure of how acidic things are. So this is why a DKA patient can be tachypnic, right? It's not because their CO2 is high. It's because they're acidotic, and that's what their brain is actually responding to. So the reason that pH is the dominant issue here is that so if you look at this equation here, again, not important to memorize the equation, just understand kind of the concept. If we add a bunch of CO2 to this side, in order for it to equalize, it's going to all push this way and produce a bunch of H+, which is hydrogen ions, which is acid, and that'll drive the pH down and make the blood more acidotic, and then ultimately will drive more respiration in order to blow off that CO2. Now, conversely, if we give a bunch of bicarbonate, what that's going to end up doing is driving this way and producing a bunch of CO2. I will say this, hypoxic drive is largely a myth. that only occurs over the course of a very long time. So in the acute setting, there is absolutely no reason to ever withhold oxygen from a patient that needs it. It is not something that will happen in the acute setting. It is not something that will even happen while the patient is in the ED, even if they are stuck there for several days waiting for a bed. That's a very long, slow process. So do not worry about hypoxic drive. It is essentially a myth. What people observe in the acute setting is not a decrease in the hypoxic drive. So it is true if you have a COPD patient that if you give them oxygen, you will see an increase in their CO2. That has to do with some other chemical stuff. It's called the Haldane effect. But that is not because of a change in their respiration. That's because of other chemical changes. And as I mentioned, DKA, lactic acidosis from sepsis, these can, because of the acid that they're producing, can drive someone to feel like they need to breathe more. And also other toxic things can cause direct stimulation of the respiratory centers. Classically, that'd be like an aspirin overdose, causes you to actually breathe faster. I will also say that, let's see here, we talked about, so if you've ever had a pulse ox on your finger while you try to hold your breath, your saturation stays high the entire time. And that's because it's not the drop in oxygen, again, hypoxic drive, not a thing. It's because of the buildup of CO2 while you're holding your breath that buildup of CO2 here causing being exchanged over to acid that's telling your brain to breathe because it's changing the pH of your blood. All right, so we have another question. Have you ever given bicarb in a cardiac arrest, saw a bump in the CO2, thought you got ROSC, but you actually didn't? So we got about 10% of people that have experienced this. So this can happen. And again, it's because of this equation here where you give a bunch of, CO2, or excuse me, you give a bunch of bicarb. That bicarb becomes CO2. You see a spike in the CO2 expressed in the end-time, and you think, oh, maybe we got ROSC. But it was actually just a bump from the CO2 that you gave. All right, so let's jump into some pathophys here. So when I talk about the difference between hypoxia and hypercarbia, and then sort of the different problems you can have. So largely, respiration or ventilation problems can be broken down into hypoxic respiratory failure and hypercarbic respiratory failure. And so hypoxic respiratory failure is when you have a low O2, and hypercarbic respiratory failure is when you have a high CO2. And the issues that cause this can be broken down into kind of lung or thoracic problems, heart problems, blood problems, vessel problems, which I think of as lungs, pump fluid, pipes in terms of troubleshooting or having like a mental model for thinking about it. So let's talk about lung problems. First, we got asthma. Asthma is sort of an autoimmune thing for the most part. Asthmatic airways, you can see there, this is normal. Asthmatic airways are thickened, they're inflamed, they produce more mucus, and then during an asthma attack, they become spasmed down. That's why we give bronchodilators like albuterol. We give steroids to reduce the inflammation to help improve the breathing. Compared to COPD, where the problem is less so with the airways here and more with the alveoli. So this is normal and this is abnormal. And the abnormal, you can see that all of that surface area of the alveoli has been kind of ground away. So there's not as much surface area for oxygen exchange, if that makes sense. Okay, so we've got another poll question here. So you've got patients with COPD, asthma, and they have inhalers, right? They've usually got their rescue haler, their maintenance haler. Are rescue and maintenance halers always separate? Like, do you always have like, this is your rescue inhaler and this is your maintenance inhaler? Because that's what I was always taught is you go to the patient and you go, silly patient, you were taking your maintenance inhaler, trying to treat your acute asthma exacerbation, and that's why you weren't getting better because you were taking your inhaled steroid, and so that's not going to work because you should have been taking your albuterol, right? Okay, so it looks like most of you are better informed than I was as a medic. So in fact, rescue and maintenance inhalers can be combined. And this is what's becoming more common now. It's called SMART, which is so single maintenance and rescue therapy. So classically, we had albuterol, which was your short-acting beta agonist, which is a rescue. And then you had an inhaled corticosteroid, which was your maintenance steroid. And those were two separate ones. You took the maintenance every day, and then you took the albuterol as needed. Well, now, and that's kind of what you would see here when you're looking at these. You got the ProAir, the Ventolin, your short activated, then you have separate inhaled corticosteroids. So nowadays, what's becoming more common is single maintenance and rescue therapy, which is a single inhaled long-acting beta agonist with a steroid all in one pump. And like Symbicort is an example. So what these do is they're beta agonists like the albuterol, but they have a quick onset and they last for a long time. They don't wear off like the albuterol does. And there's also a steroid in there. So when they are having an acute attack, they can take additional puffs, which treat it with the beta agonist, but also they're getting that steroid. So as the beta agonist is wearing off, that steroid is kicking in and knocking down the inflammation. Now, SMART therapy is showing all kinds of benefits. There's reduced hospitalizations, there's shorter lengths of stay, all kinds of great patient-oriented benefits. So in the ER, a lot of us are switching to, if a patient comes in for an asthma exacerbation, I am discharging them now with a combination inhaler, Symbicort, rather than just a rescue inhaler, because it does seem to improve patient outcomes. So luckily, most of you appear to be more up to date than I was, but it is very common for a patient to have a single inhaler now that they use. I take this 2 puffs twice a day, and when I'm having an acute attack, I take an additional 2 puffs. That is absolutely an accurate thing if it's one of these combined inhalers like Symbicort. All right. Other lung problems. Over here, we got a pneumonia. So this is what like kind of normal lung looks like. And you can see there's all this white schmutz here. This is right lower lobe pneumonia. That can certainly be causing problems again, because where you've got the alveoli, you've got like basically inflammation and infection in there, so oxygen can't get through. And on this side over here, this is lung, and this is no lung. So this lung is completely collapsed down to this little nubbin right here. This is the massive pneumothorax on the left side. So that's why they're a wee bit short of breath. So those are the lung problems. So let's talk about pump fluid and pipes. So pump fluid, pump problems. Remember, you've got the right side of the heart, which is pumping deoxygenated blood through the pulmonary arteries through the lungs, gets oxygen to come back in the pulmonary veins, comes to the left side of the heart, back out of the body, and then back into the right side of the heart, okay? Now, in heart failure, which is our main pump problem, normally the left side of the heart stops working. So fluid's going to back up into the lungs, which is the next part. Now, when fluid backs up into the lungs, it's increasing. You can imagine that there's increased pressure on the vessels in there, right? Because it's got nowhere to go. So those blood vessels get kind of stretched or built up pressure. And because those capillaries are permeable, right? Like there's normally stuff exchanging across and going through there. More fluid is going to leak out when it's under pressure than otherwise, okay? So that's how that fluid is getting out, because the blood vessel goes under pressure, and so it's like squeezing the fluid out through that blood vessel. And this is what it looks like. If you remember, when we looked at the alveoli previously, you had, oops, go back, areas like here where this was all oxygen. So this is all fluid, right? This is that pink frothy sputum that your CHF patient is catching, coughing up, because this is in the airway. This was all air before. And you see these are your pneumocytes and your capillaries and stuff from what we looked at before. And so this is why they can't exchange oxygen, because there's all this fluid that's there that's interfering with their ability to exchange gas. So looking at this again, in a normal circumstance, you've got the right heart, you've got systemic circulation feeding in the right heart, going to the lungs, going to the left heart, and going out, right? So preload is everything that's sort of coming in. Contractility is affecting what's going out, and then afterload is what the left heart is beating against, right? That's normally measured as your systemic blood pressure or your MAP. So preload is essentially what's filling the bucket in the lungs, and then afterload and contractility is what's emptying the bucket of the lungs. Now, if the lungs are full of fluid, we need to decrease the inflow in and increase the inflow out. That's how we're going to drain the lungs. So we give nitro and positive pressure to decrease the inflow, right? So we vasodilate, we are adding that pressure on the vena cava to reduce flow into the heart. And then positive pressure also actually decreases afterload and improves contractility. That's because the lungs are wrapped around the heart, particularly the left ventricle. So when you have pressure in there, it's like they're giving the heart a hug. So when the heart wants to contract and squeeze blood out, it's got that pressure around the lungs. It's also pressuring in on it to help eject the blood. And high dose nitroglycerin, this sort of our normal low dose, like the 0.04 40 mics or the 0.4 400 mics, that causes vasodilation. Higher dose nitro, when you're getting into over like 100 mics per minute, like on a drip, that will cause arterial dilation and actually drop the afterload. So in addition to the positive pressure increasing the contractility, you're dropping the pressure the left ventricle is beating against. And so if we decrease the inflow and increase the outflow, we're going to start draining the lungs. And that's how our CHF treatment actually works to get the fluid out of the lungs. Okay, it's not, the pressure is not pushing the fluid out of the lungs like people have probably told you before. Certainly that's what they told me when I was a medic. But this is how it's actually working. Okay. So those are our pump problems. Let's talk about fluid problems. The main ones are anemia and shock. Anemia, again, remember we're talking about the delivery of oxygen. You have to have something to carry the oxygen on for it to get to the cells. So if you're anemic from whatever cause, sickle cell, iron deficiency, acute blood loss from heavy periods, GI bleeding, whatever, or, trauma, or shock from whatever etiology, whether it's, distributed sepsis, anaphylaxis, whatever cause of shock. Those are kind of your fluid problems. And then if you also got pipe problems or vessel problems, this is a massive pulmonary embolism, okay? So if the pipes are clogged, then you can't get your oxygen to flow to the tissues. So that can be another problem, like PE, something in the actual vessels. So your history and physical. Let's see here. So I got another poll question here. What are some history questions that you like to ask for respiratory complaints? If you've got a respiratory patient, what are questions you like to ask that patient? Okay, CHF, I assume you mean, do you have a history of CHF, a history of COPD? Can you sleep laying flat? Good. We also ask, have you ever been intubated? So can you sleep laying flat? I also ask, how many pillows do you sleep with? Ever been intubated? Been intubated before? Previous intubations? Smoker? Pillows? Asthma? Prior intubation? How long going on? History? Smoker? Worse? Anything? Smoker? Active onset? COPD? Previous intubations? Prior intubations? Recliner? Are you sleeping in a recliner? That's a good one too. Has this ever happened before? What's helped in the past? Good. Good. These are all really good questions. Past medical history. But you're narrowing in on the common things, which is CHF, COPD. And then do you have any, I was asked, do you have history of lung or heart problems, CHF, COPD? Have you had any new or different swelling in your ankles? Are you able to, is it worse when you lay flat? Are you able to sleep flat? How many pillows do you sleep with? Those usually give me a pretty good idea of kind of how things have been going for the patient. History. So again, we can go through OPQRST. Onset. When did it start? What were you doing when it started? How long has it taken to get as bad as it is now? Does anything make it better or worse, particularly being positional, laying flat, that sort of thing? Are you able to lay flat at all? Quality. What does it feel like? Radiation doesn't really necessarily apply to shortness of breath. Severity. How bad is it? Have you ever had? Has it been this bad before? And then timing. Have you ever had this happen before? How long has it taken to get this bad? Okay. Physical findings. Breath sounds, plus minus, they're not necessarily super reliable, but you might hear crackles, rails, wheezing. They can give you some hints of what's going on. But again, it's not 100%. Just because a patient's having a COPD exacerbation sometimes, or an asthma attack, sometimes it's so bad they're not moving enough air to really get a whole lot of wheezing. And so an asthmatic, you may actually give them an updraft and then their wheezing gets worse. And that's because now they're actually moving enough air to produce wheezing, right? And then there's also cardiac wheeze, quote unquote, where the inflammation, the swelling in the airways from the fluid retention can cause a wheeze-like sound. Lower extremity exam. There's actually, I think you can get a lot of information from examining the patient's lower extremities. Do they have a ton of edema? Are they warm and well perfused? And honestly, you can look at their feet and see how well cared for they are. Are their feet gross? Are their nails well kept? Because if their nails are not, that just in addition to being like part of their self-care, if their like nails and stuff are trimmed and everything's nice and clean, that means either they are able to bend over long enough to do that, or they have someone that is taking care of them enough that the rest of their stuff's probably pretty well taken care of, right? Like you pick up some grandma that lives with family and her feet are clean and she's all pedicured and everything. I would imagine that in addition to that, like everything else on her is probably pretty well taken care of compared to the some person who's like super disheveled. Their toenails are so long it's kind of like turning into claws. You know that they're neglected and they're not able to care for themselves. In addition to looking for the edema, the perfusion, the other stuff that you see in the lower extremities. So I think there's a lot of information you get by examining the lower extremities. All right, getting to the money of it, therapies, and then we can get into cases. So bag valve mask. The one-person technique, the CE technique, sucks. I know sometimes that's a necessity based off of your resources on scene, but BVM, whenever possible, should be a two-person procedure. And you should be using I call it the two thumbs up or the V technique. You can see here where you've got the heel of your hands together at the nose of the mask and then the thumbs going towards the patient's jaw. And then you can use your fingers to come around the jaw and pull up into the mask, basically doing like a jaw thrust into the mask. You get excellent seal that way. And then someone else can bag. Anyone else can bag, right? You can have the cop bag the patient. You can have a bystander bag the patient. I mean, I wouldn't do that. But the point is that the critical part of the procedure, the most important part, is actually holding the mask seal. That is the hardest part. That's the most important part. That is the thing that the person with the most experience should be doing. The bagging, you can coach anyone on bagging. That's easy. So BVM, whenever possible, should be a two-person procedure using this technique. Don't forget our positioning. We want ear to sternal notch into that sniffing position, like we're leaning forward to take a whiff of something, not like we're going back like this. Airway super plug is going to decrease resistance, make it easier to bag. Now, the meat, the money of what we wanted to talk about today, non-invasive ventilation. So non-invasive ventilation comes in two flavors. There's continuous positive airway pressure and bi-level positive airway pressure. The main difference is that CPAP is one pressure all the time. It's basically like turning on a hair dryer and sticking it in the patient's mouth or in their face. Whereas bi-level positive airway pressure, BPAP, there's one pressure when you inhale and one pressure when you exhale. Okay. Now, the max pressure for either of these is about 20 centimeters of water. That is because 20 centimeters of water is the pressure at which your lower esophageal sphincter opens. So that is the sphincter that keeps the esophagus kind of blocked off from the stomach. And so if you go above that pressure, now it's blown open and you're inflating the stomach directly. So that's why we avoid going above 20, about 20. It's going to vary a little bit from person to person, but 20 is kind of the accepted number from anesthesia that they use. So CPAP, you basically, there's a couple parameters. One is the pressure, and that is set as the PEEP. You set your FiO2. The FiO2 is what affects oxygenation. And this is generally better for CHF versus COPD or asthma. And that is because the benefits for CPAP, remember, we're trying to increase that pressure to help the left ventricle contract and decrease the load from the RV by dropping preload, by having that pressure against the vena cava. So we want that pressure as high as possible for as long as possible. So we want higher pressure. BiPAP is high pressure when you inhale, low pressure when you lower pressure when you exhale, and it goes back and forth. So averaged over time, CPAP provides higher pressures, which is why in theory, it's better for CHF. Now let's see a demo here of PEEP on a lung.
This is a patient being bagged with atelectatic derecruited lung with no PEEP valve.
So we got no PEEP valve right now.
A PEEP valve is applied, and you can see over several breaths, the lung is recruited.
So now we got a PEEP valve. You can see the lung is starting to recruit.
The PEEP valve is turned up to 10.
So now this is PEEP at 10.
The lung is maximally recruited. This gives you more safe apneic time and functional residual capacity.
See how expanded and happy that lung looks instead of all deflated and sad? Okay.
You can see immediate derecruitment and deflation of the
You
lung.
lose, as soon as the PEEP goes away, it gets all deflated again. Okay, so that's the effect of PEEP. And it helps with recruitment over time. And again, with that positive area pressure for CHF. Now, BiPAP is a little bit trickier because there's two pressures, and there are a couple different ways that we can describe the two different pressures that are involved. Now, basically, there is a pressure when you breathe in and a pressure when you breathe out. That's the part that you need to understand. Now, there are a couple different ways that those numbers can be expressed. So again, you have, and that this is expressed in one of two ways. So you either have, you say what the top pressure is and what the bottom pressure is, and that's EPAP and IPAP. So you say 10 over 5, so it's 10 when you breathe in, 5 when you breathe out, okay? Or this is expressed as PEEP plus pressure support. So you have PEEP of 5 and a pressure support of 5, which means we have PEEP 5 when we breathe out, and then pressure support of 5 means it gives us 5 extra when we breathe in. So PEEP of 5 with a pressure support of 5 is same as 10 over 5 EPAP over IPAP. So the expiratory pressure and the FiO2 equals oxygenation. So this is adjusting the PEEP or the EPAP, and the FiO2 is how you're going to adjust oxygenation. And the inspiratory pressure or the pressure support is what's going to give you your tidal volume. So you think about that when you breathe in, the pressure support or the IPAP is what's giving you that extra air. So that's how the patient's going to take a deeper breath, which makes sense how it's going to affect the tidal volume. And then when you breathe out, that's the PEEP, and that's what's keeping the lung from collapsing, and it's helping keep it expanded. So that's how it's affecting the oxygenation. Okay, so you've got those two different levers. Whereas CPAP, we just set a pressure and an FiO2, and that's mostly affecting oxygenation. If we need to affect ventilation, BiPAP is better because we can help give more pressure when the patient's breathing in, so they can take larger breaths and blow off CO2 and get more tidal volume. So like I said before, this is the trickiest part about BiPAP is understanding how the numbers are being expressed. So you can have expressed as IPAP, EPAP, where you're just naming the pressures, 10 over 5, versus PEEP plus the pressure support. So PEEP of 5 plus pressure support of 5 is the same as 10 over 5. Similarly, a PEEP of 7 with a pressure support of 7 would give you 17 over 7. So titrating this. So for oxygenation, you can increase the PEEP. Now, this is where it gets tricky, right? So if you have a system where you're giving the PEEP and the pressure support and you want to increase oxygenation, all you have to do is increase the PEEP or the FiO2. Now, if you have a system where you input the EPAP and the IPAP, you have to increase the EPAP and the IPAP together. Now, the reason for that is, let's say you're on 10/5, so that means you've got a difference of 5 when the patient breathes in. If you increase the PEEP, but not the IPAP, those pressures are getting closer together. So you're increasing the PEEP to help with the oxygenation, but now the patient is getting less pressure when they breathe, less pressure difference when they breathe in to support their breath. So if we know that they're breathing okay with 5, then that means we need to increase those numbers together. So for ventilation, you can. So now for ventilation, we want to increase the difference between those between the breathe in and the breathe out pressure, right? So you can either increase the pressure support or increase the IPAP, depending on how your machine is set up. But again, the goal, if you want to increase oxygenation, then we want to move both of these numbers up together, however we do that on our machine. And if we want to increase ventilation, then we want to increase that top number while leaving the bottom number alone. And that'll increase our ventilation, however we do that on our machine with those two parameters. So quick look at the protocol. The main thing that I want to, it's exclusions is hypotension, decreased level of consciousness, aspiration risk. This kind of goes without saying here because it goes along with decreased level of consciousness, but an exclusion would be apnea. So if you're going to put, these are all spontaneous breathing modes. So a patient has to be breathing spontaneously in order for non-invasive to work. And again, we are always worried about decreased level of consciousness, like if they vomit and they aspirate, blah, blah, blah. I'm less worried about that if you're being diligent about being prepared to suction, because that's the whole concern, right? Because the main concern with someone being on non-invasive and then someone being on non-invasive and then having this mask on is that they're going to get stuck on this and then like put in the corner and like forgotten for a while, right? And if that's very different that they're gonna, vomit, not be able to take off the mask versus you have this on them and you're staring at them with a Yanka or a catheter, like ready to go. Those are two very different scenarios, but we still have this like, oh, you can't put an altered patient on BiPAP or CPAP. I won't say I do it all the time, but I don't think it's as firm of a contraindication as necessarily we make it out to be.